Good morning, everyone, afternoon, and welcome to this week's Power Hour. I'm here with my colleague, Christina Natcherdog and Franklin Walker, and we have some wonderful guests for today's meeting. I'm going to hand it over to Franklin Walker as our moderator, and we'll go ahead and get going.
Super. Thanks, Aubrey. Welcome, everybody. First thing I want to do is let everybody go around and introduce themselves. Today's topic is going to be emergency medicine, and we're going to talk about COVID testing and COVID vaccines. We had this same session in April, but things have changed demonstrably since April. I think when we were on in April, folks were preparing for a New York type surge that never materialized. And we were talking about that. And of course, things are a lot different now. So what I'd like to do is start with Dr. Stephen Small. Stephen, can you just give us a quick background on where you are, where you're practicing, and what your practice is, please, sir?
Sure. I'm an emergency physician, actively practicing in Charlotte, North Carolina with MEMA, and we work in the Novant system.
Super. Cheryl, how about you?
Hi, everyone. I'm Charul Haugan. I'm an ED physician at UNC Rex with WEMA. And then I also am one of the physician leads for the UNC Health System ED groups. And we meet weekly with the 11 ED leaders across the state. So we get to kind of hear tales from the front lines, particularly with regard to COVID on a pretty regular basis.
Super. Thank you. Jennifer, are you with us now?
Jen Parker Cote. I am a attending physician at Vidant Medical Center, East Carolina University Brody School of Medicine in Greenville, North Carolina. I'm also a medical toxicologist.
Super. Thank you. Aaron, can you give us a quick background on yourself, please, sir?
Of course. So my name is Aaron Primzen. I'm an EM physician. I'm credentialed at about 12 different hospitals between South Carolina, North Carolina, Virginia, anywhere from places where it's single coverage 24-hour shifts to large residency programs. And then I also have my own family practice urgent care offices where we do quite a bit of COVID testing throughout North Carolina.
Dr. Mike Utek, are you with us now?
Yeah, I'm here. I'm sorry. I was just finished up another meeting. Sorry.
Can you give us a quick background on where you're practicing, please, sir?
Yeah, I'm currently at the Durham VA emergency department. That's where I am, practicing there.
Super. Thank you, sir. Okay. Thank you guys for giving us that background. Clearly, we've got folks that are practicing all over the state, so they're going to be seeing a lot of different stuff. Cheryl, I do want to start with you, given that you've got, 11 EDs kind of in your purview. And tell us a little bit of what you're seeing right now across your system, given where we were in April. Of course, things, as we said, are way different. So just a little bit of background on what you're seeing right now, please, ma'am.
Sure. Yeah. I mean, I think, when we last gathered, we were talking a lot about these sort of Herculean preparations that were being made and, tents everywhere, and the hospitals were shutting down elective surgeries, and the EDs sort of turned into ghost towns a little bit. I'm sure you all have kind of experienced that, right? That huge drop in patient volume. Patients weren't coming in. When they did, you saw them immediately, and then they, went upstairs because there were all these empty beds. It was a little bit like a utopian emergency department in some ways, because you could see people quickly, they got moved quickly, and it was the really sick folks that needed emergency care that were coming in. What we're seeing now, Franklin, to your point about we all kind of braced for the New York surge that never came, things gradually reopened in the hospitals, right? And then now the surge has been sort of steady but slowly approaching, and then now we're now seeing the numbers that we were preparing for previously. But the difference being, I think that, I don't know about you all, but most of our entities have not yet canceled elective surgeries, or hospitals are super full. Patients are sitting in our lobbies forever trying to get, on a bed. We're seeing them in the lobby, in triage. We're seeing them wherever and however we can. It's just a very different reality. And I think all of that sort of sitting on this foundation of really exhausted healthcare workers, where it's just, they're COVID weary. I think it's really hard to maintain vigilance in a lot of the things that we were so focused on before. I mean, we do have PPE available, but kind of the constant, switching of the PPE. We had envisioned sort of these, areas where all COVID people would go, and now all the people are COVID people, right? You fell and hurt your hip, and you also have COVID. I mean, it's just the community prevalence is so high that it's really difficult to have that same PPE vigilance from patient to patient to patient. And I'm sure you all, are probably also seeing, our staff starting to get sick from COVID, and our docs and our nurses and our staff. So there's the staffing burden as well. So I'll shut up. That's a lot.
Oh, that's great. Thank you for that background. Stephen, how about your view from down in the Charlotte area, please, sir?
So we have very similar type experience going on right now. Our volumes are not quite back to where they were, but they're pretty close. Our largest problem right now really is just the boarding situation in every hospital. I mean, every hospital in Charlotte is completely filled, no beds inpatient, no ICU beds, and the waits in the emergency department are astronomical. So we really feel it from that standpoint, because just trying to get a patient back to see them is very, very difficult right now. And it's very challenging for folks who don't have COVID and have, other medical problems to get them through the system. And I think that's probably our biggest issue right now. We certainly don't feel the PPE problem as we did before. And I think that, the concern is whether within the next month or so, there's going to be some more of those extreme measures. Like we have not had any of our elective surgeries canceled, but you wonder whether that could be, in the process. And I think that the other thing is, whether they're going to start looking at opening up, some of the large tents and things like that to try to place these patients who are, quote, semi-stable but need to be admitted. All of these discussions that we had back in April are starting to come back up again. So it'll be interesting to see in the next 30 days what happens with that.
Right. Dr. Utak, how about your Durham VA experience? What's going on in Durham?
Yeah, there's definitely been an uptick from where we were. I would probably say in the last 3 weeks or so, we've definitely had, it's much like Cheryl says, every patient now is COVID positive. It's now, also understand that this is the time of year where acuity goes up naturally. Like we usually admit a lot of pneumonia. This is the time of year that, we have more psychiatric admissions. And so just in general, we usually will start losing beds because of severity of illness. Now that coupled with COVID, of course, is up. I know now in our hospital, as of 2 days ago, we were probably having like maybe 1 or 2 or 3, maybe up to 7 COVID admissions. Currently we have 20, not meaning I'm in the ICU, but we have 20. So you can see that in and of itself is a sort of a benchmark of where we are. And we, as of yesterday, we had about 70 employees that were COVID positive. So it's starting to affect how, just the staffing requirements. Yeah. And I'm sure that's going to continue to grow.
Thank you. Jennifer, how about your view from Greenville?
So very similar concerns. Our ICU was full, last I heard actually this morning. We are having lots of boarding issues in the emergency department and trying to create spaces to see patients. Unfortunately, we actually, as of today, we had a certain COVID area part of the hospital, a part of the emergency department. And as of today, like at 3 a.m. or something like that, now the entire emergency department will be seeing COVID patients because of the numbers. I think that PPE is starting to become a concern again as well. So it's kind of we're at capacity. We're still allowing like 1 visitor per patient that's afebrile, which I'm not sure how much longer we'll be able to do that. And I'm sure that they'll also have to stop the elective procedures as well soon, but we still have them ongoing. So it sounds like it's similar across the state.
Yeah, thank you. And finally, Aaron, I want to get to you because you're in a unique situation. You and I have talked about your practice before and all that COVID testing that you're doing. So tell me what you're seeing in the field, maybe a little bit different from your colleagues here. What's going on with the practice in terms of the testing that you guys have been doing, which has been incredible, some of the stories that you and your staff have shared with me, and how that's going for you.
Absolutely. So first of all, thank you for even having us. To be honest, as ED physicians, sometimes we don't feel like we're heard well. And, when ED physicians do talk out, you've seen cases, Dr. Lynn in Washington, Dr. Gilman in Arizona, Dr. Phillips in Walter Reed, they get fired when they talk out. So, the fact that you're giving us a voice here is impressive. ED physicians, since especially most of us are part of groups that are not really attached to the hospital really doesn't seem to think of us as, part of them. We're considered the enemy, and, if you talk out or you explain your concerns, they get rid of you. They have the group that you work for terminate your contract. Since I work in such a larger variety of hospitals, they're all pretty much the same, to be honest. There's no beds anywhere. The 24-hour place that I work at, single coverage, it's a freestanding ED. There's nowhere to admit anyone. I mean, during a regular flu season, there's nowhere to admit anyone. Literally flying people across the state or across state lines just to get a bed. So with COVID on top of it, as ED physicians, we knew that it was going to be absolutely miserable come wintertime for us to even admit anyone. So it's exactly what we've expected. People bored. There's no beds anywhere, yet the ED can always make extra beds. You put a chair here, you put a chair there, but you're stretching out your nurses, you're stretching out your physicians. The stress is all on us. And then at the same time, we don't have the backing of the hospitals so much. We don't have the backing of the public anymore. So it's quite a frustrating position to be in. I used to work 200 to 300 hours a month in the ED. I used to literally work almost every day. It got to the point where just the stress of it has gotten to me, and I'm limiting how much I'm doing that to be in the clinic itself. Like you explained, we have 2 offices in Charlotte. We do the majority of COVID testing in the Charlotte locations, as well as throughout the state, really. We do about 5,000 to now 7,000 tests a day.
Mm-hmm.
We start off with 2 clinics where we were initially just doing maybe 100 tests a day, and we thought that was fantastic. That we had access to our own lab. And it all actually started from the March, April timeframe when, there was no ability to test. And you had to be on the phone with the FDA, the CDC, the local health department, just to get approval to take one person and get tested. So what I did was I actually created our own lab, a high complexity lab through Elite Diagnostics, where we were able to do as much testing as we needed. So we test anyone that wants to be tested. We do it all cost-free, so the patient has no charge at all. We have some of the fastest turnaround times throughout North Carolina. Usually we get our results back in about 24 hours on the regular PCR test. The lines are insane. I mean, right now we're testing at 20 to 25 locations a day throughout the state. And any location we open up, there's always a line of at least 100 to 200 people in their cars just waiting to get tested. And, my staff's been out there when it was 95, 100 degrees. Now they're out there when it's 30 degrees and when it's raining. And it definitely takes a toll on the staff out there. But luckily, most of the patients are quite appreciative of what we're doing, which is, what we saw in the March, April timeframe in the ED, where everyone was thanking us the second they used to walk in. A lot of that appreciation in the emergency department's gone away. It's back to how it is, where we're expected to be there, beck and call. But on the lines out here, it's very different. You know, these people really do appreciate all the testing capabilities that we do have.
Thank you for that background. That's very interesting. You guys are doing a ton of testing. It's just incredible the volumes that you're seeing. So guys, recently we've had, you know, the Pfizer vaccine has been approved, come out. Stephen was talking earlier about he had just had his. I don't know who else has had theirs. And then the Moderna one is on the way, I think, from what we can tell. So a couple of things I want to get into. One is your triage different now than it was in April when we talked to you guys for your patients, assuming you've learned a lot in the last several months? And then the second part of that question would be, now that the vaccine is available on a 1A, 1B level for, you know, you guys are probably, most of you are 1A, right? How do you foresee that changing your practice? Okay. So Cheryl, given the 11 that you oversee, would you be kind enough to take on that question first, please?
Yeah, sure. I mean, I think in terms of our triage process, I mean, we all remember, you know, back in March and April, it was like you've got these screening questions and then, oh, they may have COVID, and you like stick them in this other area. Now it's like, yeah, we still do the questions, but the basic assumption is that everybody has COVID. You know, we can no longer trace it back to that, you know, large gathering you went to. Now it's like you went to the grocery store and you have COVID, right? So I think we still ask the questions formally, but I definitely think that our triage, you know, protocols and sort of, it doesn't really drive decision making because the basic assumption is that everyone has COVID. And then, and I'm jealous that I can't see your name. Jennifer, that you said you just filled up your COVID area. I mean, that happened to us, you know, a while back. And so they just go everywhere. It doesn't even really drive our decision making after triage in terms of where we put them, because really we're just having to put them where we can put them, waiting room, wherever. We don't have anywhere. And in terms of the vaccine, I definitely think it's too early to know. I'm actually going this afternoon to get mine, so that's exciting. But, you know, it's hard to know. There's still definitely cautionary guidance to say, you know, just because people have been vaccinated, we still don't know their ability to be asymptomatic spreaders, right? We can't say you may be protected against manifesting any symptoms of the disease, but that's not to say that you won't be an asymptomatic spreader. And so I think we have to continue to urge, you know, appropriate practice with regard to protecting yourself and protecting others. And then, you know, my fear is that in the same way that right now, sometimes what I'm seeing is people will have an exposure and have a negative test 2 days later and be like, no, it's good, I'm all good, I don't have it. You know, they don't understand kind of the life cycle of the virus in the incubation period. I have similar concerns that people will be really falsely reassured and think now that they've been vaccinated, they're sort of superheroes and they're immune and they can now go about their life because, you know, I'm good, I'm vaccinated. So I have a lot of caution around the vaccine. I absolutely think it's great. I think people should get it if they're comfortable getting it. But I'm worried with the COVID fatigue that the general population has. Once they all start getting vaccinated, I'm really worried that it's going to be really business as usual and life as it used to be and lots of gatherings and things like that.
Mm-hmm. Interesting. Mike, I want to come to you with this question next, given what I would assume that maybe being at the VA, maybe your patient population is a little bit different than the rest of these folks. And the folks that you're seeing might be a little bit older. I don't know, you know, again, the vaccine question is an interesting thing to me with that population. Are they more skeptical or not? You know, so would you take a whack at that question, please, sir?
Yeah, I mean, obviously we do have a, you know, sort of a much more geriatric population. I have not heard amongst any of them that they were resistant to the to getting the vaccination. Mm-hmm. Some of our staff, not physician staff, but some of the ancillary staff, they've expressed some concerns. Mm-hmm. And interestingly, and almost predictable, some of the our minority staff have said, you know, I'm just going to wait and see what happens to you guys, and you know, sort of thing. And obviously, it's, you know, we are all touting that it's very, very safe, and we're going to get. I got mine yesterday, actually 2 days ago. So, but amongst the population itself, and now the Durham VA, we draw from 27 counties, so we're getting a lot of people from a lot of different areas. And I know in our population that they're ready for it and they want to get it. And for the way we're doling out and the way we're doing it right now is because we have like a long-term care facility in the VA called the CLC. And so like the 1A tier is anyone that is coming has 100% contact with COVID. So it's ER, and then like the CLC, the high-risk patients are where the vaccine is going to be concentrated.
Super. Has your triage changed any since we last spoke in April, Mike, in terms of what's going on with your COVID patients?
Yeah, I mean, honestly, we had sort of like this designated COVID area that it was just been dismantled. I mean, there's no point because everyone has it, and a lot of our patients that end up being admitted, we have to COVID screen them anyway, and they'll come in for some innocuous thing and they're COVID positive. So we just pretty much treat everyone like COVID. That does not mean that if you come in with a hip fracture that we're all suiting up and everything and burning through PPE to go see you, but we're still mask and face shields and some limited covering. And then if the result's positive, then things change. But
yeah, that's interesting. Jennifer, I know you've got to leave us in a few minutes, so I want to come to you next and let you tell us about your view on those two questions that I gave out there a little bit ago.
Regarding triage, I think we're still asking the questions. There are many patients who slip through that triage process. So my assumption is that everyone has COVID, and I kind of approach it that way. I mean, I'm not completely gowning up, but I'm definitely wearing masks and eye protection. And I usually use 1 N95 per shift, just because we've had several providers go out on COVID leave, and it's an issue because all of a sudden now you have 2 weeks worth of emergency department shifts to fill at the drop of a hat. So, and your second question, remind me what your second question was again.
Well, one was about the triage, which we talked about, and then one was how the vaccine might be affecting your practice coming out as a 1B and a 1B. Well, I would assume all of you guys, my guest panelists, are in that 1A level,
group.
right?
Yeah. So my understanding is that we still need to wear masks. I mean, you have to get the full vaccine, and then you have to have the immune response. I think that from my understanding is we should all still be wearing masks. I'm afraid that the public are going to think that they're going to be able to go back to business as usual, and then we'll have another spike. And you need about probably 70% vaccination rate for any kind of herd immunity. And I'm not sure if the public's trust is there yet with the vaccine. And I feel like I'm fighting a lot of misinformation, even amongst patients and even amongst some healthcare providers. So, and that is going to be another challenge, I think, out there as physicians is counteracting misinformation.
Right. Thank you. And if you've got to go, thank you for being around for a bit. Appreciate you.
Thank you for having me.
Absolutely. You take care. Stephen, can you think about those two questions and let us know what you're seeing or thinking down there in the Charlotte area, please, sir?
Our triage is essentially back to what it was prior to COVID. There's really no change at all in things other than, we still ask the COVID screening questions, but, we treat everybody like they probably have it. I would say that, providers all kind of choose to what their comfort measures are in terms of using PPE. I have some of my colleagues who just, wear full stuff with every patient they see. Most of us, I would say, are probably, in the realm of wearing a mask, obviously everywhere. And then if you have a high suspicion of someone has COVID, then you'll, put all your gear on. Really to try to conserve and frankly, because we have not had very many people in our practice test positive doing these kind of measures. So, whatever we're doing seems to be keeping us safe.
Yeah.
So I'd say from that standpoint, in terms of the vaccination, we just started getting it yesterday. I got mine today. It's kind of slow going with that, but it's it's happening. I think there's just a lot of, just like everybody, I mean, no one really knows what to expect right now. The questions about, what if I had COVID 3 months ago, should I get vaccinated? This is coming up. And then that question about, do you still need to wear your mask if you get vaccinated? And I think that at least the stuff that has been circulated, around where we are, the kind of general thought is, the vaccine seems to be very safe and people feel pretty comfortable with that. The problem really is that no one knows, how effective it ultimately is going to be. So how long does it take until you actually grow some immunity? And then how long will that immunity stick around? And, with mutation of the virus, because we're already seeing people who got infected in March and April are now getting reinfected right now. That used to, back in the summer, you heard almost none of that. We're seeing a good number of those folks. That's not few. We're getting a good number of that. So, the question I think people wonder is that if you get vaccinated, how well is that going to keep you safe against a mutated strain in the future? I mean, it's the same kind of thought process behind getting your yearly flu vaccine. You get your vaccine, some years it's really good, some years it's really bad, but we all still wear a mask if you're going in to see somebody that you think might have the flu, because you really don't know how well you're immunized. And I think that's kind of the mantra that we're all trying to keep in the back of our minds, that you get vaccinated, but you still wear your PPE because you don't want to give it to somebody else, and you certainly don't want to get it.
Right. Thank you. Aaron, I want to come to you last, and I want to tag a little bit of extra onto those two questions, because I think it's going to be interesting in your business model, since you're doing all this testing, how you see this new vaccines that are coming out affecting that, right? So the first two questions plus that 1C question, please, sir.
So from our standpoint, the vaccine really doesn't change how my staff should be acting. I mean, again, everyone should be gowned. Everyone should expect that even though you're vaccinated, there's still a chance that you could put yourself or your family or someone else at risk. So it's been made very clear to my staff that even though we're going to be 1A providers, that we still have to do the same thing as always. In regards to, is the general population going to listen to this? I mean, they don't listen to anything anyway. Luckily, it's until March, April timeframe when the general population is even going to have access to the vaccination. At that point, they're going to see that we haven't all mutated, we haven't all just dropped dead. They'll feel more comfortable to actually take the vaccine. The way it's actually spread out, where we do our highest risk population first, I think actually will work to benefit the general population actually getting vaccinated. They're going to see that the people who are touting it are actually the frontline people who are taking the vaccination. And I definitely appreciate all the providers who are taking pictures of themselves getting vaccinated, the people who are outspoken on social media who are doing it. Unfortunately, I'm not going to be able to get until next week, so I'm still waiting on mine. But once it is, I do get it. News reporters have already been invited to watch us get it done. Now, our other standpoint is we want to be the ones that are vaccinating the population through our business model. So we want to go from testing people and have that hopefully drop down to where we're actually vaccinating people. So we actually purchased quite a few of those ultra cold freezers that most people don't have access to. So we've been sitting on 7 of them, where, the whole state might actually have, I think, 10 total. So we've been waiting for this since April or March timeframe, something like that. And the point of this was, as someone said, the minority populations are definitely the ones that are going to be the most hesitant to get vaccinated. They're not going to be going to the large hospital centers to get their vaccinations there. You have to bring it to them. And you have to make sure that it's done safely, appropriately, where it looks like it's professionally done, to make sure that the population trusts it. Even in my own staff, to be honest, a lot of my medical assistants, my CRNAs, my medics who are minority populations are definitely refusing it. And it's disheartening to me because we're in Charlotte, we have 300 employees here. I've only gotten 50 yeses to who wants to get vaccinated. And, I've already given multiple talks to them. My CEO has given them multiple talks. Once we get vaccinated, like I said, we're going to do it in public so they can all see that I'm getting it. And I'm hoping it changes their thought process. But it's really sad that, so few are willing to trust something like this, even in the medical field. What we do hope to do is actually be able to have our ultra cold freezers hold the vaccinations and then use mobile units to actually take it to locations that really need it, and to keep it on dry ice, since you can keep it on dry ice for a short period of time and actually vaccinate the population that way.
Super. Thank you. That's very interesting stuff. And you're planning to, shift your business model, and that's great. I want to talk now a little bit about your workforce, and you guys have made mention of it. And again, I want to think longitudinally since April. Have you guys implemented any new changes in training based on what you've seen? How is your workforce adapted? My guess is there's a lot of burnout because you guys are working really, really hard and long hours. That's what you guys do in general. But I want to kind of talk about that a little bit. Mike, can you talk about that at the VA a little bit, please, sir?
Yeah, I don't really think that much has changed. It's we sort of got into a pattern, and that pattern has seemed to be, as in Steve's situation, we're not having a lot of our our crew out, and so really our workflow is about the same, and the way we approach is the same. So. I think what we made a few adjustments along the way, but overall things have pretty much continued as business as usual, to the best of our ability.
Gotcha. Cheryl, I want to come to you and talk about UNC and what's happened over there, maybe.
Yeah, and I mean, if you're talking about like staffing volumes. Is that one of the things?
Well, I want to, a couple things. One, I want to know if over the course of this pandemic, since we talked in April, are there things that you guys have seen in terms of you're changing the training for your staff? Certainly, we talk about PPE and other protocols, and now you guys have been pretty consistent. You're treating everybody that walks in like they're COVID positive. Okay, so how does that affect the training for your staff? How's your staff holding up? What's their morale like? Some of this conversation you and I started having the other day. So I think you've got a wealth of information across the UNC system that you can share with us.
I manage some expectations, maybe not a wealth of information, but I mean, I think that, we're definitely seeing staffing shortages. And, as ED people, we are highly sensitive to hospital operations. We are the canary in the coal mine, right? So even if we feel that our own staffing is holding up fairly well, which we do have some docs out and we do have some ED nursing out, we are also doubly affected by the loss of inpatient staffing. And so we already are operating at capacity, our beds are full, but when we lose inpatient nurses in addition, it just kind of perpetuates this inpatient boarding in the EDs and gives us fewer and fewer beds to even work out of. And so I think that the staffing impact across the entire hospital system really manifests as delayed care at an ED. And so that, from a volume perspective, that's one of our struggles, in addition to the beds being actually filled upstairs and in the ED. But then in terms of morale, I mean, it's exhausting. It is just trying to maintain this level of hypervigilance. Initially when you brace for a few weeks or a month or two, you can sort of dig in and prepare for that. But it is now, 7, 8, 9 months hence, and people are really COVID weary. I mean, they're just tired. We've had a lot of turnover of leadership, physician leadership and nursing leadership in the EDs across the UNC system. And I can't help but think that some of that has really been driven by just this incredible stress and the long hours and all of that. And so, yeah, I think it's hard, you know, I think it's taking a toll. And I don't think we'll really appreciate the full extent of that toll until months or even years to come.
Yeah, thank you. Stephen, tell us about what's going on with you guys.
Well, I would say that within our practice, we have got almost 90 providers. So it's about 60 physicians and about 30-something APPs. And from a provider standpoint, I don't really get the sense that we have a lot of burnout right now. I think everybody's been handling it pretty well. In fact, I would say it's a little bit of the opposite, because we've had, like other practices have, we've furloughed some shifts and had some shift modifications based upon patient flow. And so I think that, you know, the providers and everybody kind of would like to get back into a regular work schedule where it's not so haphazard. But I would absolutely echo, I think burnout is absolutely severe within the nursing ranks. And we have seen some really bad situations with that. We've had a lot of nurses quit throughout the system from various reasons. You know, it's just various. Some of it is simply, it began with just having to take care of their kids. A lot of childcare issues drove that in the beginning because kids couldn't be in school. And now it's kind of perpetuated itself into not just including that, but they're just overworked, too many hours, too many patients they're responsible for taking care of. And it's across the board. It's upstairs on the floors, it's in the emergency department. So, I mean, that I would say is a huge, huge issue. And if there was one group of healthcare, you know, employees or healthcare providers that are just really taking heed, I think it's the nursing staff. And something ultimately is going to have to be done with that, because I mean, this is just, it's a snowball that's just growing and rolling, and there's got to be some sort of long-term fix for that.
Yeah. I remember during our conversation in April, a couple of things that you all had hit on was that you thought that the folks that might be having a heart attack or, you know, sprained ankle or whatever that used to come into the ED to see you guys were now not doing it, right? Because of fear of COVID. So they were staying at home maybe, and then, you know, the ambulance would have to go out and find them. I wonder if that's still, if you're still seeing that, and that's continuing to be a problem. Since I've got you right there, Stephen, are you still seeing that?
No, not like we did before. I mean, people are coming in now. They're just aggravated that they have to wait 8 hours to be seen.
Sure.
But we haven't seen that kind of thing.
Okay. Thank you. And then let's talk a little bit about health disparities, because we had also mentioned that, not just in when Mike said a lot of his staff, people of color maybe were more reluctant to get the vaccine. And certainly we know the numbers on COVID has affected those folks in those, you know, those ranks of the people of color more heavily. Do you still see that happening, Cheryl?
Yeah, I mean, you know, we talk about social distancing and isolating, and that's a luxury that not all people have, right? I mean, so I think, you know, as a function of sort of socioeconomic status, these folks are more at risk for vaccine. As a function of insurance status, they're less likely to seek care. As a function of public health, you know, implications, they can't quarantine, they can't socially isolate, even if they do have positive tests for COVID. They're living in conditions that just don't allow for that. And then I think also as a function for some folks, you know, what we're seeing from a occupational hazards, you know, the meat packers and the food plants and the farmers. I mean, it's really difficult. And a lot of that does have sort of an ethnic overlay and a racial overlay. And so, I think it is so multifactorial. And then I think, kind of hearing what some of y'all have said, which I haven't really heard much about, these are also the same population that are less trusting of the vaccine and perhaps will be more reluctant to get it. I think it's just going to continue to exaggerate that disparity, right? So as people of different racial persuasions and socioeconomic persuasions who already have inherent protections from contracting the virus or protections from having the luxury to be able to seek care are now also the ones that are more likely to get vaccinated. That disparity is, I think, only going to worsen. So somewhat alarming.
Yeah. Aaron, I want to come back to you and let you tell us about what you're seeing in these many months of testing. I don't know if you keep the data on what kind of demographics are coming to your testing sites, right? Are the folks of color, of less privilege, what percentage of those folks are coming to get tested?
So, and Franklin knows this well, the rest of some of the people in this group actually. I presented a topic for our KIPL leadership conferences regarding the disparities for the Hispanic population, especially related to COVID. And what we noticed early on was, and if you looked at the percentages of the demographics, a very skewed number of Hispanic patients who were testing positive. And we realized that, and just like Cheryl said, she was dead on, it was because they could not socially distance. Their job was considered essential, so they were at work while the rest of the population was at home. They didn't have access to healthcare appropriately. They all live, 3 generations in the household. So it spreads like wildfire. Now, we have seen that the percentage is starting to slowly decrease throughout North Carolina, just because obviously the general population is now getting infected. But for us, since we are doing cost-free, since my clinics are specifically located in low economic areas, we still have a very high percentage of minority patients. And that's the patients that we've been looking to test this whole time. And through our contracts with NCDHHS, we are specifically sent to counties where testing is not done, where the big healthcare systems don't find it financially suitable for them to do testing. We go in there and we do the testing for the counties.
Thank you. Yeah, I remember your KIPL thing. That was really interesting. So Aaron, I'm going to stay with you for a second. You talked a little bit about how you would see your business model changing. Let's think about being, March, April, May, when more of the general population has had access to the vaccine. As Stephen said, we don't know how this is going to work out. If you're going to, how long you're going to have, when do you get immunities, when do you lose them, and that sort of stuff. But I'm wondering if you were on a planning team for a pandemic, the next pandemic that comes. We've learned a ton out of this one, right? What would you recommend in the workforce, your workforce, that you guys would do to prep up for the next time around?
So, problem is, what I expect is going to happen is we're all very heightened right now. Everyone's prepared. The finances are all being pushed into healthcare so we can fight this. Realistically, by the time the next pandemic hits, we're going to be seeing, recessions. So healthcare is going to get cut. Your health departments are going to lose their funding. All this money that was pushed into testing abilities, into PPEs and all those services, everything is going to go away, realistically. And by the time the next pandemic hits, be it 5 years from now, 20 years from now, we're not going to be ready. It's going to be the same thing all over again where, we're not going to have stocks of PPE on hand, no matter how much people think they're going to plan for it. Administration is always going to find a way that this needs to be cut because it's not an issue right now. Something else is more of a pressing issue. So as much as we've learned, the reality is we've learned nothing. I mean, there were plans for pandemics put in through I believe it was Obama's administration, where, they had all these stockpiles. Those stockpiles expired. We, cut funding for it. It was never replenished. And all of a sudden we get hit with a pandemic and literally the country needs to shut down. So we have that time to build back up again. So I'm not a very optimistic person about that.
Well, but maybe a very realistic view, sir. Cheryl, what do you think about that question? Looking into the crystal ball.
I don't want to think about another pandemic, Franklin.
Okay.
Yeah, I mean, I think it's just this concept of like sort of how do you prepare and stay prepared for this once in a century situation and sort of an unimaginable event. But, if you've got infrastructure to do it, if there were stockpiles, if there can be stockpiles, I mean, that's how you do it. At the beginning, and if you all remember, of course, I mean, just finding PPE, something as basic as we don't have masks to protect frontline staff. I mean, there's basic foundational things that do need to be stockpiled. So it's sort of a tragedy in many ways, the way this whole thing has unfolded.
Yeah, well, I will say that that's probably an unfair question of me to ask you too. So I'm going to move on to something else and go back to Mike. Mike, let me ask you this. Do you, over in Durham in the VA, have you guys engaged any community partners to help you in all of this, like the Red Cross or anybody else external to the VA system? Again, I know you're not just in Durham, you guys are all over the state, but I'd be interested to know if there are any other community partners working with you guys.
No.
No. Okay. Well, that's okay. Stephen, how about you down in Charlotte? Uh-oh.
Sorry, I had to unmute myself. No, not really.
Okay.
I mean, I think the only thing that we have benefited from, we have a private group, so we're not, we fund ourselves. We're not employed by the hospital system. So we had a nice partnership with North Carolina Medical Society and gotten some funding for some PPE and things like that has certainly, our staff has benefited from. But and we've had some local folks donate PPE to us as well, to our practice. So, I'd say that would probably be the only partnership that I can think of.
Super. Yeah. Aaron, have you guys had in all these, Cheryl's raising her hand. Just a second, Cheryl, I'll get to you. Aaron, you're doing a lot of stuff in different counties and stuff. Have you engaged with any community-based organizations to help you guys either get out the word, promote your testing sites, that sort of stuff?
Yep. So in regards to promotion, we definitely do. We reach out to community leaders. So mostly we target churches.
Okay.
Because, your church already has a set population.
Right.
They're a high-risk population, usually older population. So we go to church leaders first. We explain what we're doing. Usually, majority of them are completely all for it. They want to get testing done, so they look like they're doing a responsible job, especially since churches are being opened. In regards to other types of assistance, there's a group, and I forget what they're called, the 2020 group, something like that, 20-something. It's like a volunteer group, and they do a lot of charity work. Mm-hmm. They actually help find us staff members, people who can help with our line controls, because again, there's 200 cars at a time, and it does get out of hand. So they do get us some support that way. Mm-hmm. Realistically, financial support, though, the only people who have really helped us is the society. This has been a very financially taxing thing for us. Yeah. I mean, we just took out $1.5 million credit line yesterday because we're nearing pretty much the end of what we have. I mean, I think we're negative around $3 million now. So it's pretty ugly.
Yeah.
You know, the payers are not paying what they're supposed to. They're pretty much denying everything that we send in. So financially, we're hurt.
Yep.
Now, you know, this luckily the state and some organizations have sent us PPEs, but when you're doing testing in 25 locations a day, we burn through gloves and masks and gowns like there's tomorrow.
Yeah.
Yeah.
Yeah. Yeah. Sure do. Cheryl, you had your hand up to say something.
Well, I just was going to say, you know, it's sort of hard in the ED because, you know, it's all sort of unplanned acute care and people sort of show up. And so I don't know if this exactly fits with community partnerships, but I think there's been a lot of interesting clinical partnerships, at least that in the UNC system that have been evolved, and primarily with regard to home health services and extended and enhanced home health services. We've really partnered with a lot of our home health agencies for things that would previously would just be slam dunk admissions to say, well, if we can get these 5 things set up from the ED, then we probably can get this person home, and finding, you know, nurses that can sort of go out the next day, and then physicians that will kind of own that patient for 2 weeks or a month under the home health auspices. And so it's really been great in at least trying to offload some of those admissions and help us a little bit with flow. And it's one of the models that may survive COVID, you know, and I think so there could be some good sort of learning there long term that can help us, you know, keep our hospitals open.
Yeah.
And the beds, inpatient beds available.
Okay. I want to ask one quick question of you while I've got you, and then we'll move on because we're getting close to the top of the hour. I think it was Stephen that had mentioned about the nurses, and, you know, but I know the nurses and a nursing shortage, burnout, got to take care of the kids and everything. But across 11 hospitals, a nursing shortage is a huge thing, okay? And rates are going up and everything else. What's your plan?
I know, you got one?
Okay.
So a couple of things. Yeah, so a couple of things. I mean, we have, at least specific to the ED, because we do have such a coordinated system ED group, we've implemented, you know, in terms of the burnout and people leaving, there's a stress first aid program that we've brought, which is really sort of peer stress support and we've kind of done a train the trainer model for nursing leaders across the system, just to be able to implement at their own entities, and it's just really kind of a great way to help a peer support network for stress. You know, the issue of travelers, I don't know if y'all are dealing with this much, but the rates for traveling nurses are unbelievable. I mean, they will bankrupt a hospital. But again, we need nurses. Like Steven said, I mean, we need nurses, and, you know, their presence is paramount. We can't provide care without nursing. And so the traveling situation is unbelievable. And I mean, I think, you know, what would be great is if we had sort of a system-wide nursing float pool where we could try to kind of consolidate available nursing resources and float them around. And it's something we've talked about, and I think we'll be working on for the future, hopefully not for the next pandemic, but, you know, just to help alleviate that burden. But, you know, you can't just manufacture nurses. And the problem is, this is not a localized nursing shortage. It's everywhere. It's not like when there's a storm and you can bring in the utility workers from Virginia help, and it's everyone's short, right? And how do you sort of drum up nurses? How do you increase your workforce by 20% to account for COVID outages? You can't.
Yeah. Well, I tell you what, let's do. It's close to Christmas, and I want to say I'd like to leave this on a positive note. So I'm going to give you an opportunity to start the ball on this, Cheryl. What would be your Christmas wish for the next 3 months, given all the stuff that you guys are dealing with?
Does it have to be realistic?
Well, you know, hey, this is our last Power Hour for 2020. So I'd like 2020 has been an interesting year. I'll leave it at that. So I'd just like to leave 2020 with my ED group being on an upbeat from Power Hour.
Okay.
Yeah.
So I think, you know, really just anything to sort of really thank the healthcare workers and the sacrifices that they've made professionally and personally for them to be able to sort of receive the acknowledgement and recognition that they need. And I would wish away any long-term implications of this crisis. I would just like wish that away, that, you know, dig in for another couple months, and when it's over, it's truly over. That would be my wish.
Super. Stephen, how about you?
I would wish that this would go away a lot sooner rather than later, so that people can kind of get back to their pre-COVID lives. And I'm optimistic. I'm an optimist and think that this will ultimately go away just like it came. But I think that, you know, if I could wave my magic wand right now and wake up on January the 1st, I would love for it to be a lot better sooner, so that we can kind of get through all this and people can try to enjoy themselves more freely.
Super. Dr. Utek, what would you like to have happen?
I'd like to be able to invite Dr. Small to Raleigh and sit in the PNC Arena, watch Carolina Hurricanes game, and drink a really expensive beer.
I think that's fantastic. I think all of us should do that. Aaron, tell us what you would wish for, please, sir.
So, I mean, literally they took the words out of my mouth. I have not seen the inside of a restaurant since February. I would love to go back to the restaurant.
Yeah, super. Well, listen, it's been a privilege to have you guys twice in this year on Power Hour. You're a great group. You're doing great work. We stand with you in support of you guys as all healthcare providers in North Carolina with your backs up against the wall during this pandemic. My Christmas wish is that you all get some rest. And so I'm going to close out this year by thanking Christina Nottadog and Aubrey Cuthbertson, my colleagues, for putting this show together. We're going to look forward to 2021 being a better year. And so I'm signing off. Christina Nottadog, I'll leave it with you.
Thank you, Frank. It sounds so serious when you call me Christina, so I kind of sit up straighter. Thank you all so much. We are just so thankful, and as I put in the chat, we'll continue to ensure that we do provide a voice in this forum. And we'll probably come back and send you another little email and say, hey, can you be part of another one? Can't thank you enough for everything you do. And I sit here and I'm taking notes and getting ideas, and just want to make sure that you know that we're here. And if there's anything that we can do, if there's an idea or something you think that could be helpful, let us know, because we are here in order to help with resources and whatever we can do on our end. But a huge thank you to all of you, and Franklin, you're just a born moderator. I just have to say it. This should have been your other career had you not been doing this. You should be like on some sort of major network. So privileged to be working with you and Aubrey, and privileged to be able to serve you guys and be thankful for the work that you do for us on our end, and taking care of patients. Without any further ado, I'd like to hand it over to Aubrey, and then happy holidays. And I do hope you get some rest, and I do hope that you get to have quality time with your loved ones together as well.
Thank you all for being here today, and we see you and we hear you and we're here for you, and thank you all for doing what you're doing. It really means a lot, and we know that you're probably not thanked every day, so thank you from us. The recording is going to be available within the next couple of weeks. With the holidays coming up, want to make sure to give a little leeway time. We'll be back with Power Hours on January 8th of 2021, and that's all for today. Thank you all so much for being here and taking time out of your day to be with us, and we will see you next year.
Thank you.